Hi, this is Scott Miller. Welcome to my Top Performance blog. I have a big honor today, and that is speaking with a person who has been a teacher and a mentor of mine, a colleague, and I would say friend now. He is an internationally known researcher, was a professor at the University of Wisconsin-Madison, and is an author, Dr. Bruce Wampold. Hi, Bruce.
Hello, Scott. Thanks for the invitation. I look forward to a great conversation as we usually have.
Thanks for that. And I've appreciated those conversations over the years. And also something that from the time I was a graduate student, your rigor and organization, the way you methodically deal with the questions that come up for you as a practitioner and as a scientist. And so I wanted to start there because for me, at least, as I look to you for counsel, as I watch your example, you've always been somebody who is questioning the dominant way we think as a field. And one of those questions came in the first edition of your book, The Great Psychotherapy Debate, which, and you'll just have to permit me to say this, and the second edition, I believe personally that 25 to 50 years from now, people will be saying, why didn't I hear about this book before? It's as I said before, it's a very methodical approach to the research literature, and one of the largest questions I think facing practitioners at the present time. Here's what you said on page 2. You said, the scientific evidence will be presented that shows that psychotherapy is incompatible with the medical model, and that conceptualizing psychotherapy in this way distorts the nature of the evidence. You then went on to say, cast in more urgent tones, the medicalization of psychotherapy might well destroy talk therapy as a beneficial treatment of psychological and social problems. The first edition was published in 2001. We're now in 2022. Have we made progress?
Well, that's an interesting question, Scott. And it depends what you mean by progress. Are treatments more effective than they were? I mean, would you take or prefer a therapist today? Or could you go back to Carl Rogers or some of the other preeminent therapists of a couple decades ago and get just as effective treatment? I believe that really the effectiveness of psychotherapy hasn't progressed too much. Okay, but let's qualify that because psychotherapy is remarkably effective.
Yeah.
You know, it's as effective as medications for most mental disorders without the side effects, longer lasting, et cetera, et cetera, et cetera. So we're doing a great job, but there's a challenge to the field to actually improve. And the improvements are going to be incremental, but important, or they could be important. Now, have we progressed scientifically? I think we do know more about how psychotherapy works in a number of different areas, and we can go into those. But we've also wasted an immense amount of resources, time, and effort on the wrong questions. The questions that emanate from the medical model, like which treatment is the most effective treatment? Now, if you have cancer or a gastric ulcer, that's a pretty critical question.
Yeah.
But it turns out in psychotherapy, that's the wrong question. Okay. And we really have to look to other factors that are important in the quality of care.
More important questions that we could be asking, what would those be?
Well, it's interesting, you know, in medicine, we focus on the treatment, and actually we want to ignore the person prescribing the treatment. So, you know, it's not which physician we go to, it's which treatment the physician gives. So if you think about it in those terms, there's this idea that we should be examining treatment. But it turns out in psychotherapy, and Scott, incidentally, also to a large extent in medicine. The person administering the treatment is absolutely critical. So in psychotherapy, the most important factor is the skill and competence of the therapist delivering the treatment. There are some really quite amazing CBT therapists. When I say amazing, I mean really powerful outcomes. So when we talk about psychotherapy, we got to talk about outcomes. But there's some rather poor CBT therapists, and the same goes for psychodynamic, ACT, motion-focused therapy, whatever it is. And, Scott, I've looked at these data, tens of thousands of therapists and patients, and it's just so absolutely clear that the therapist makes a difference.
So maybe those poor therapists just haven't attended enough CE training events or had enough supervision. Maybe we should just mandate more hours of those kinds of events.
Yeah, well, you're baiting me because we know the answer to that. There's no evidence that attending CE units, taking a course online or going to a workshop. Now, I'm not opposed to learning new treatments and thinking about your skill, but it's clear the way we do continuing ed, and actually you could extend that to the way we do training of therapists, and the supervision models largely has little impact on the outcomes of psychotherapy. We've been doing the same supervision model, since the beginning. Well, tell me about a difficult patient you have. And out of the 15-minute supervision session, 47 minutes is on the diagnosis of the patient, some characteristic of the patient, not on the skill of the therapist to respond to this patient. Now, they may say, well, you should take a different tack, but not on the actual skill in responding. So, we're both quite interested in breaking this down. What do these effective therapists do in a session that differentiates them from other therapists?
You're saying then that more progress could be made if we focused on individual therapist development. And I'm pulled to go there and ask you about that. But first, I have to know if that's the case, Bruce, and if the data are so overwhelming, why the pull of a medical view? If we define that medical view as you have X problem, I apply Y method, you get Z result, and it's predictable, thereby absolving the individual therapist of any accountability. Hey, I did the treatment the right way. You didn't respond, therefore it must be you. So why that pull?
Well, interesting question. And it's not just the therapist who says this. It's actually managers of care, systems of care. If you're responsible for 100,000 lives, the mental health of 100,000 people, it's very easy to say, I'm going to make sure all the clinicians in my system of care deliver the very best treatment. And if anyone questions me, I can say, my therapists are giving evidence-based treatment. So it goes all the way through the system. It's not just the therapist. Now, let's go back a little bit. So this idea about testing the efficacy of psychotherapy, all the clinical trials that, we can go back years, kind of the pioneers here, David Barlow, Steve Holland did all these clinical trials, and others, of course. It really was important in one way, and that is psychotherapy or psychological services, however you want to label it, got accepted in the United States mental health system. So we get paid through insurance, we get paid through the government programs and so forth. That's a very important event. Okay.
Yeah.
On the other hand, what we did is we prioritized that way of thinking to the exclusion of understanding the factors, for instance, related to the therapist and the relationship, which are absolutely critical to the success of therapy. Now, if you want to get money from NIMH, you have to look at comparison of treatments. That was where the funding was. If you want to be published in the best journals, you have to publish clinical trials comparing treatments. The system is set up to reward that kind of behavior. And, frankly, people's reputation and their egos. Hey, I did this clinical trial, and I got $6 million from NIMH to compare cognitive behavioral therapy to interpersonal therapy, the NIMH TDCRP study of depression. I think it was $6 million that study cost. 6 million is probably 50 million now. And that, to the researchers and the authors, is a feather in their cap. These people became well known, and they were well known before, but there's just this, the system's really set up to reward that, Scott. And I can give you lots of personal stories, what it's like to be on the outside, taking a different view and a critical view of that, because you don't get money, you don't publish in the same journals, and you're marginalized. But better to be marginalized and right, I think, than to be in the mainstream and have it wrong.
It can be very lonely on the outside, and it can also, at least for me, lead me to wonder, what the hell is wrong with me? Because the whole world is going this way. They're all wearing wide lapels, and I come out with the small lapels, and they don't look at me and go, oh, he's setting a new fashion trend. They say, he's not one of us. He's not interesting. He's out of date. How as a researcher have you dealt with that?
Well, Scott, I would disagree about the kind of loneliness. I think my work has an impact. And what's interesting as I reflect on this, I've given, as you have, workshops all over the world and working with therapists all over the world. What's interesting is I rarely get invited to academic institutions to give lectures. So the therapists that we work with, they resonate with this perspective because they have boots on the ground, so to speak. They're doing it. They want information about how to get better. At least many, if not most of therapists have that motivation. So it's been tremendously rewarding. So I wouldn't say that, hey, I spent my career, no one's listened to me. But it's interesting to note the kind of divide in our field between kind of the clinical scientists, as they like to be called, and clinicians and people doing research on naturalistic data or practice-based evidence, if you will.
So I'm once again pulled in two different directions. The first is counsel as a senior in our field, somebody who has been there, through this, done that, to entry-level counselors, the younger people in the field. And the other way I'm pulled is to think about some of the most recent trends, because it's evident that the square peg and square hole thinking that has characterized much of the time I've been in the field, if you have anxiety, you do CBT, if you have a trauma, you do EMDR, that is in the wane. But that doesn't mean the academics don't have a new idea. And the new idea is this common core protocol. We're going to emphasize processes of change. We're going to teach you how to respond to these processes of change. So I'm tempted in those two directions. Take either one.
Well, yeah, you don't need to give me too many prompts to get going. Scott, I'm retired from university, so I don't get to lecture and have an audience very often. So stop me, please, if I go on. I spoke earlier about how clinical scientists and clinical trials really made psychotherapy a practice that was acceptable and paid for by healthcare systems. Absolutely critical to our success. But there are some trends that I think are rather disturbing. One is this idea that we can mandate which kinds of treatments for which length is sufficient to treat patients. So more and more care is limited. Okay, you might get 6 sessions, If the type of treatment is not mandated, then at least the number of sessions are. And the training in primarily clinical psych programs is very manualized based protocols. And in fact, there are clinical scientists that says we don't need psychologists or even licensed professional counselors. We can have technicians provide this kind of treatments because we have these manuals that are prescriptive about what should be done. That to me is frightening, because then it becomes a commodity or a standardized treatment in the same way we might give antibiotics for a bacterial infection. It just reduces what makes psychotherapy work. This relationship is absolutely critical to success. Now, I should say, because I get misinterpreted about this continually, therapists should have a cogent, coherent treatment program that they believe will be effective. And more importantly, the patient will believe that if they do this difficult work, they will make progress towards the goal. And we can get into that at some point. But we're becoming a commodity, and it's pressure from payers, government, excess demand, right? We don't have enough services to meet the needs of people suffering. So let's do it as quickly as we can, as cheaply as we can, and that will be the most efficient way to provide treatment. Transdiagnostic protocols, we can get into that. The increased focus on process, I think, is good. But from what I see, at least for many of these, they're not very much different than the evidence-based treatments they replaced. So
can you say some more? Because we don't have to name names or anything, but you hear huge claims made about what are moderating variable or aptitude by treatment interaction studies that say, if you do this, this is the predictable result, maybe not in a grand scheme, but in a small level, we can sort of work the client by following these processes to the desired outcome. And the claims are really remarkable, and generally numbers like 10, 20, 50,000 different interactional effects that say that if we follow them, we could benefit.
Well, we're going to get into this idea of precision mental health services or personalized mental health services. I kind of laugh because what we do really from the beginning is personalized. We obviously adapt the treatment to the particular person who's sitting across from us. I mean, even the most kind of orthodox CBT therapist, I think, does this. There's a case conceptualization, understanding of the patient. So we already do that. Now, the evidence on matching patients to particular treatments and even to particular therapists now, if you read some of the literature, the effects are relatively small. Still, the most effective therapists achieve commendable outcomes across a range of patients. So rather than trying to find a therapist that seems to be the best fit for me, just give me a therapist who over the course of their career achieves commendable outcomes. And I know one of the reasons is they're flexible. They will know me to a great extent and flex how they do things to match me. You know, it's interesting, Scott, I'm kind of a culinary guy. I like to cook and I like to go to good restaurants and eat. And sometimes the front of house staff, the wait staff, just irritating. They have a formula. You know, my name is Joe and I'll be your server tonight. And then occasionally you get somebody who's just understands they're at the table, not too much or too little.
Yeah.
And I always said that's a great wait staff.
Yeah.
And then my wife says, well, you know, they don't treat every diner just the way they treat you. The good wait staff knows exactly how much you want them hanging around. That's like therapy.
Mm,
But can you flex how you do this?
mm.
So I think the large data and the machine learning and all of this has the potential. We all believe, yeah, this was a good match. Just get the right therapist, I'll do well. So I'm not opposed to that. But if it obscures what we know about what makes good therapy, which is where we should be concentrating,
Mm.
it will just be another technological attempt to improve outcomes.
I guess I'm skeptical in some ways, simply because our field has been full of promises that if you live long enough, you see that pretty soon there's a new promise. And the old one, you're not exactly sure if it was fulfilled or not. So whether it's moving through the behavioral era to the cognitive era to the era of the brain, then trauma, attachment, you see these trends come and go, and then you see the outcomes remain rather flat. You've given this, I think, impassioned presentation about the therapist. So is that the object of focus? Is this what you would advise a young therapist to entering the field to focus on? What's the future direction?
Yeah, well, let me just say, when you say I'm skeptical, that's kind of our middle name, Scott, because we've been around long enough. We've seen the various fads that come in, new treatments, transdiagnostic treatments, precision mental health, et cetera, et cetera, et cetera. And you do see maybe some results that say, well, maybe this is different. And then over time, it really doesn't seem to make too much of a difference. And, we give up things in our field, not because the evidence says they don't work. I mean, when I went to graduate school, I learned systematic desensitization, which nobody does anymore in the same way that it was done originally. But it wasn't because the evidence showed it wasn't effective. It's just we went on to something new. So one exception might be measurement-based care or practice-based evidence or feedback-informed treatment, however you want to call it. I think through the years, and there's still trials running it, that measuring patient progress and patient processes or therapy processes does lead to better outcomes. I think that's a robust finding. And I think that has changed the field for the better. I think now there's relatively strong evidence that shows that really what differentiates more effective therapists than less effective therapists is a set of sophisticated interpersonal skills, relationship skills that are evident when emotion is really strong, challenging interpersonal situations, either challenging the patient challenges us directly, or they withdraw, or they're fearful in a session, or they're passive. These are challenging situations. Good therapists are able to engage in those difficult emotions in the moment. The research of Tim Anderson and others have replicated it since, but I give Tim credit for the first studies that showed that the facilitative interpersonal skills, as measured in a challenge test, could actually predict who were the most effective therapists. First time ever in our field that something measured outside of therapy predicted the outcomes. So I think we know that. We got to act on it now, though, Scott. We got to use deliberate practice and training to teach those skills.
So say some more about that part, because right now, and sometimes when I'm out and doing presentations, I say our field, especially in a PhD program, selects for qualities that often aren't reflected on the facilitative interpersonal skills inventory. We attract amazingly smart, amazingly accomplished people into graduate programs in psychology, but not necessarily the most relationally adept people. In fact, to get perfect scores on the GRE, you have to be a little bit relationally impaired, maybe.
Well, I don't know about that, Scott, but you're absolutely right. Tim Anderson, and there's a group in Germany that did something similar, but he measured facilitative interpersonal skills in the first week of a clinical psychology training program, put the results in a drawer or in the hard disk on his computer, and then 2 and 3 years later looked at their outcomes. And it turned out that those facilitative interpersonal skills predicted the outcomes of when they started to see patients.
2-3 years later.
Yeah. So, Scott, let's go back to how we select for graduate school. You had GREs, letters of recommendation, grades. Okay. So if you were to say, those are poly-orthogonal to this interpersonal skills we're talking about, the people would say, the admission committee would say, but Scott, we also interview these candidates and we can detect who's going to be a good therapist by the interview. Well, it turns out, not only in our field, but this is a industrial and organizational psychology general outcome. Interviews do not predict.
Yeah.
So a group in Germany, the Schottky group, showed that ratings by interviewers of therapists for admission had no predictive ability. Social skills inventory, standardized, validated inventories of social skills do not predict.
Right.
It has to be the social skills that are shown, interpersonal skills, in these challenging environments that predict. So these are the things we need to train. We can train these skills, but micro skills were not too far off the mark. But the way we really taught those skills was far from optimal. Okay. And Scott, you've done a lot of work on deliberate practice. If you're going to learn to be an athlete, a quality or expert athlete, a performance musician, Anders Ericsson studied this for his lifetime. The thing that differentiates those who are at the top of their fields is deliberate practice. And I love the quote of Pablo Casals. He's 80 and he practices 4 or 5 hours a day. And they say, you're the best in the world. Why would you need to practice? Oh, well, I'm still making progress.
Right.
And it's not just, I'll just play these scales. He studies exactly what he needs to improve and then iteratively improves.
Yeah. So routine outcome monitoring, measurement-based care, feedback informed treatment, the pioneering work of Tim Anderson and his team and the FIS, these are all fairly recent in terms of evolutionary processes in the field. Is this the beginning of something new? Do you see it as eventually pushing out these older ideas? What's the time frame here that we're talking about?
I mean, the measurement-based care, and that's the term. Again, we adopted that term from medicine. So it's interesting, but it's becoming the name to use. So measurement-based care and deliberate practice of the skills, I don't think is a paradigm changing event in the evolution of psychotherapy. I think it's an important and will marginally improve the quality of care if used properly. But this marginal improvement has a great impact on the outcomes of care.
Yeah.
So it isn't something, when I say marginal, it isn't something like, oh, it's no big deal. It is.
Right.
Because if we can improve the quality of care 5, 10, 15%, that's going to be And there's studies to show this. If you had reassigned patients who saw the poor therapist, not to the better therapist, but just to any of the other therapists, the effect on the number of patients recovered is quite remarkable. So this will have an effect. Psychotherapy is an interpersonal process, and there's limits to the change that's going to occur through that kind of interaction. So I don't think we're going to have a paradigm shift where if we could live another 60 years, psychotherapy is going to be twice as effective as it is now.
Do you see the paradigm at some point by 60 years shifting more from the dominance of the medical paradigm to the contextual one? And would that help even more?
I don't know, Scott. I don't think it's going to change dramatically. I would think it more as kind of a subversive process. Look, we're in the medical system. We're trained in universities, programs to a large extent. But we can influence how that training takes place and the way services are evaluated. And so we're already seeing, I think, even in the most rigorous clinical psych programs, more of the idea we need to measure outcomes and look at outcomes. I think the idea of interpersonal skills is having inroads even in the CBT world. So we're making progress in that way. So I don't see it as this, even though I called it the great psychotherapy debate, I don't think we really want to focus on either or. Let's just kind of infiltrate and improve what we're already doing. And I think we can do that. You know, I was trained in the sciences. I have my undergraduate degree in mathematics. Never took a psychology course. So in a way, I'm an outsider in that way. But and you know my personality. I don't like to be told this is the received view and you better believe it. And anybody that knows me even slightly well will know that. But that's not the important point. The important point is that we have to stand up for what we think will actually result in better outcomes for patients. And, you know, Scott, you and I get along so well in our discussions because we're both dedicated to that proposition. What's most important is that we actually research and train and implement procedures that are going to result in better outcomes.
I know that you're involved in something innovative, and I don't know if it's possible to even mention this, but even the idea that I have to meet with you in a room or even a virtual space in order to help you benefit from psychological care, even that idea, I think some of the work you're doing right now that I know about, that's being challenged as well.
Well, Scott, we should have another discussion about digital mental health solutions. You know, during the pandemic, we went from, the patient comes in and has to sit across from me so I can read their nonverbal behavior. We can't do this over video conferencing. Well, the evidence, we made a rapid shift in about a week or two to this video conferencing without a decrement in outcomes. Now, it may not be universal for all therapists and all patients, but on a population level, it's just as effective. It turned kind of our world upside down in some sense. Well, there's lots of other kinds of digital solutions coming online. Some of them are quite scary and others are quite encouraging. So we should have a discussion about that. But
I'm going to hold you to that then, Bruce.
Yeah, let's do it.
Let's do it in the future. In the meantime, let me say thanks so much for decades of mentorship and work together, and even up to this point today, you're an inspiration.
Well, thank you, Scott. And you know, we have been friends and colleagues for, I don't want to say 40 plus years. And again, what unites us is this effort that we really want to do something not to further ourselves, further the field, but to help patients. And I valued that collegialship with you, and our conversations always push the boundaries of what we're thinking. So thanks to you as well.
Thanks, Bruce.
Thank you, Scott.